Hello, everybody. Thank you so much for joining us for today's session of the CRISM Addiction Rounds series. Please note that this session is being recorded and will be posted on the CRISMPrairies.ca website. I would like to open our session with a territorial acknowledgement. The Canadian Research Initiative in Substance Matters has members from across all of Turtle Island, the land now known as Canada. We acknowledge that Indigenous peoples are the traditional guardians of this land and respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs disproportionately harm Indigenous people. As such, we commit to ensuring this series is anti-racist and anti-colonial and serves as one way to dismantle colonial structures that contribute to ongoing oppression. If you have questions during the session, please use the Q&A feature to send questions to the hosts and panelists at any point during the session, and the last 15 minutes will be reserved for questions from the audience. We really value your feedback. Please complete the series evaluation, which you'll receive by email after the session, and completion of this evaluation will also allow you to request a certificate of attendance for your records. It now gives me great pleasure to introduce our two speakers for today. Dr. David Hodgins is a professor in the clinical psychology program in the Department of Psychology at the University of Calgary and a coordinator with the Alberta Gambling Research Institute. He is registered as a clinical psychologist in Alberta. His research interests focus on various aspects of addictive behaviors, including relapse and recovery from substance and gambling disorders. David is one of the founding members of the CRISM Prairies Node. Dr. Didier Jutras-Aswad is an addiction psychiatrist and chief of the Department of Psychiatry at the Centre Hospitalier de l'Université de Montréal, or CHUM. He is a full professor in the Department of Psychiatry and Addictionology at the University of Montreal and serves as president of the University of Montreal Expertise and Collaboration Center on Concurrent Disorders. Dr. Jutras-Aswad is also a principal scientist at the CHUM Research Center, where his work focuses on substance use disorders and their comorbidities, particularly mental health conditions. His research program combines clinical and translational approaches, leading national clinical trials to develop and evaluate innovative interventions and models of care for substance use and concurrent disorders. Welcome, and David, I'll turn it over to you to start.
Thank you very much, Catherine. And I wanted to congratulate you on starting this new national series. I know you've been doing something similar locally for a long time, and it's just really wonderful that we're kind of starting to do it on a national basis and have a dialogue and the opportunity to network and learn from each other across Canada. So thank you for originating that. So I'm going to share my screen here. Okay, so we're going to give two examples of applications of contingency management, and I'm going to start. I'll talk a little bit about what contingency management is and a little bit of background, and then I'll talk about a project that we did here in Alberta, and then I'll pass it to DJ, and he's going to talk about a national level project that is ongoing. In terms of conflict of interest, I don't have any associated with this presentation. And the research that I'm presenting was funded by the SUAP program, the Substance Use and Addictions Program from Health Canada, and with support from CRISM. So I'm going to talk about this project. We called it the PRISE project. We're going to tell you what we plan to do and then what we actually ended up doing, how we implemented it, and then talk about some of the results and discussion. So contingency management has been around for a long time. So back in the 60s and 70s, behavioral psychology was very popular. And the operant conditioning principles were first applied to alcohol, and then were kind of expanded to apply for other drugs. Contingency management became kind of more fully developed in the 90s during the cocaine epidemic. It's probably more friendly to refer to it as motivational incentives. So basically, behavioral principles are used to reward good behaviors, good specific behaviors associated with recovery or with treatment from addictions. So the original goal was to incentivize drug-free urines. So if you think about cocaine, we wanted people to be cocaine-free, and we provided rewards if they came in on a number of times a week and were able to provide a drug-free urine sample. So it can be a freestanding treatment, but more often it's an adjunct to sort of other treatment approaches. And it's been, well researched. There's on the bottom of this slide, there's numerous meta-analysis of its effectiveness. So originally it was drug-free urines. So abstinence was what was being incentivized, but it expanded to other, specific behaviors. So attendance, sort of engagement in attendance in treatment, medication adherence, employment, um, specific treatment goals, sort of within treatment programs, exercise, and medication adherence for, specific disorders like psychotic disorders, for example, have all been studied and with the contingency management model. It also has been studied in a variety of populations and with a variety of substances as well. So these are examples of adults, adolescents, dual diagnosis, pregnant women, alcohol, cocaine, opioids, cannabis, nicotine, and methamphetamine as well. So there's a very large database on it. Um, and it's probably the poster child for the um, treatment that is empirically supported but not well implemented, not widely implemented. Um, the research on abstinence-based CM, shows that it improves not only abstinence, but retention and compliance and quality of life in the person as well. So it enhances treatment outcome. There's similar kind of outcomes for incentivizing attendance at treatment, although the abstinent effects are smaller. So um, providing incentives for attendance is less expensive. It's more straightforward, but its results may not be as extensive as abstinence-based contingency. So that's research, and there's lots of research on this. The practice is that in Canada, it's pretty infrequently used in clinical practice. And part of that is the sense that there's some negative attitudes towards it. So, what are these negative attitudes? People said that it's, bribery. We really should be encouraging intrinsic motivation in addictions. People have to want to change, and that's kind of what treatments is about. That it might cause increased use of other drugs not targeted. So if you provide an incentive for someone to be cocaine-free, they'll reduce their cocaine, but they might increase something that's not being monitored, like alcohol or cannabis or something else. Incentives can be diverted. And, while you're providing the incentives, there's an effect, but once the incentive is removed because it's extrinsic, then the effect will go away. And then finally, it's expensive. And really all of these have been debunked. The one that's probably the most relevant is it is expensive. There's an expense for a treatment program to implement a contingency management service. In the long term, there's probably cost savings, but in terms of actually, a program budget, there is a cost to doing it. And we'll talk about kind of how that can be reduced a little bit over time. So we actually did some research on attitudes in Canada. So we did a national survey of awareness and attitudes of among people who were clinical service managers in addictions programs. So we had responses from almost 300 individuals representing 103 programs. And what we discovered is that about a third, 36% were familiar with contingency management. So awareness was not that universal for sure. But there was at the same time a real openness to learning more and receiving training and receiving support around contingency management. So 85% of participants were quite open to learning about it and perhaps implementing it. Of the 15% that weren't, we asked them in kind of open-ended ways what the objections were. And about half of them were kind of philosophical objections, like this was just not something that fit with the orientation of the program or the philosophy of the program. And then the second biggest category were logistical concerns. It just seemed hard to do and they weren't sure that it would work within their program. But generally, the takeaway message was that there's an openness across Canada, and some of what we assumed were attitude barriers were really not very frequently acknowledged or cited. So there's lots more details in this article if you're interested. So the project that we did, the PRISE project, we wanted to evaluate the effectiveness of attendance-based contingency management in outpatient treatment, addiction treatment programs. So we worked with the two largest outpatient counseling programs in Alberta, the one in Calgary and the one in Edmonton. So these are the Alberta Health Service clinics. And our original intention was to do a head-to-head comparison of incentivizing abstinence through drug testing versus incentivizing attendance. What our primary outcomes were and were for the study and remained for the study were, in particular, we were looking at retention and attendance. So it was really focused on, can we better engage people with secondary outcomes of substance use and tertiary quality of life impacts as well. We were also originally intending to focus on methamphetamine users because those individuals, had particularly high dropout rates in the clinic. And we wanted to see if we can get those people to stay in treatment longer so that they then would have, the positive benefits of treatment. Then came COVID. At some point, we're going to stop talking about the impact of COVID on our research results, but it's too soon. So this was a study that was very affected by COVID, and the treatment that was offered in the clinic went from in-person to virtual, almost entirely virtual. So we needed to figure out how to do virtual delivery of contingency management. And originally, our idea was to use a prize cabinet at each of the clinics where people could see what was available and would choose their own prize. That's sort of one of the traditional ways that contingency management is offered. We changed it to gift cards, and we sort of basically set up a bank for each of the participants where they could collect their monies and then withdraw them when they wanted to withdraw them. We thought and couldn't really figure out a way of practically reliably testing for abstinence remotely through drug screening. So we really removed that study arm, and it was a comparison of treatment as usual versus treatment as usual plus contingency management, where attendance was incentivized. And we also then understood pretty quickly that we wouldn't be able to recruit exclusively people who used methamphetamine. So we opened it up to kind of basically all clients, patients of the clinics. So we pre-screened 200 people, and the people that were excluded were mostly, the largest group were deemed ineligible. Now, even this was an effectiveness study, and we wanted to include kind of all clients, but we needed to limit it to people who actually had a treatment plan set up that involved at least weekly attendance. And not every client had that kind of intention, or the treatment in both of these clinics is very individualized, and a counselor meets with the client and decide what groups and what services they might offer, and there's individual counseling and so forth. So a lot of people were ineligible because they didn't really have a plan that could be incentivized. However, there were lots of people that didn't show. They were pre-screened and agreed, and we just didn't get a hold of them again. And so, that's one of the disadvantages of this being a research project, because if this were an implemented procedure in the clinic, the contingency management probably would have started immediately, not, there wouldn't have had a pre-screening step. Sorry, I need to move my face around here. Yeah, and then once, when assessing eligibility, there were 96 people, and a few people were excluded, but not many. 93 were then randomized, and, half and half to contingency management or treatment as usual. And we analyzed almost all of them. There were a few people that were then deemed ineligible subsequently. In terms of our final research visit, there was quite a dropout rate. You'll see that people engaged in treatment, but didn't necessarily follow through with the research component. And I'll talk more about that as we go along. So, as I mentioned, treatment as usual was highly individualized. The two clinics serve, general community, but end up having slightly different demographics. But mostly people had some sort of individual therapy. They had groups, these were all now remote groups. Most of them were drop-in groups, so they weren't closed groups, they were open groups. Calgary, there was a RAM clinic. There wasn't in Edmonton. Psychiatry, I think, was available at both settings. So the contingency management, the remote contingency management, we put together kind of a very basic computer program, because we wanted people to have the opportunity to be the ones to choose their prizes, or to have an active part in this. We didn't just want to inform them. And we adopted what's called the fishbowl technique in contingency management, which is a way of making contingency management less expensive. So rather than giving a specific reward as an incentive, people would gain a lottery ticket, essentially, the opportunity to draw from a fishbowl where they could potentially win a jumbo prize, or a large prize, or a medium prize, or a small prize, or in 50% of the opportunities, an affirmation. And the prizes we gave as gift cards, and people then had a sort of a bank that they would save this money. So I'm just going to show you a little visual of this here. There's the fishbowl. And so this is what people would be interacting with. They get a sense of what they've won already. How many entries do they get this particular draw? They got 3, so they then got a jumbo prize. They got a small prize, and they got then an affirmation of some type as their third one. And then this is the balance in their bank account, and then they had the opportunity at any point to redeem the balance. So the person working on and providing the contingency managements, of course, would discuss with the person, what are they saving for? What are they hoping for? They would congratulate them on, when they got a larger prize and so forth. So often in face-to-face applications, that's done in a group. And so people see other people winning, and it's a kind of a whole social thing. So we tried to replicate that somewhat, but we weren't able to replicate it completely, of course. So the sample looks very much like you would expect from an outpatient addictions clinic, 37 years old, mostly white. People in Edmonton had more frequent substance use than the people in Calgary. The people who completed were older, and the marital status was kind of usually people who are married are more likely to complete. Here it was people that were married or separated or divorced or widowed were more likely to complete. People living common law were actually less likely to complete. So that's a bit of an oddity. Results. In terms of retention, you can see here that people who received the contingency management were retained for twice as long as people who had treatment as usual. So a pretty robust effect. And that wasn't just at the beginning of the 12 weeks. The incentives were provided for 12 weeks. It continued over the 12-week period. In terms of total sessions, you attended longer, you did attend more sessions, of course, and this was also a very robust effect that was true across the time period. We also looked at consecutive attendance, which was also better in contingency management. Abstinence, these are not significant results, so it looks like contingency management did better, but this wasn't a significant result, likely due to power issues here. And the abstinence as an outcome, didn't necessarily, not every person had that as their treatment goal. Sort of implicit, it was implicit for almost all of the clients likely, but it's an imperfect measure of substance outcomes. It was very complicated to do this. We used the timeline follow back, but to derive something more specific with the variability was challenging. So those were results were during the 12 weeks of the contingency management. We followed people then for an additional year. Again, we didn't find significant results with proportion abstinent. But if you look at the bottom there, our follow-up rates were really not very good in the follow-up time. So conclusions, the remote contingency management was effective for retention and attendance outcomes, not clearly effective for substance use and quality of life. It was less cost prohibitive than providing incentives for abstinence and reduced barriers to access. It was just a whole lot easier to implement and people's willingness to participate. And this incentivizing engagement actually fits the treatment model better than abstinence, because we tend to meet the clients where they're at, and that might not mean that their immediate goal was abstinence or even their ever goal was abstinence. So the engagement incentive really kind of helped. So we do have on the CRISM Prairie's websites an implementation manual. It actually includes videos where the clinicians involved in the study recorded kind of examples of what they said to clients and how they provided the incentives. So, I encourage you to take a look at this if you're at all curious about how you might think about implementing contingency management in your particular service. And so thank you. And I'm now going to pass it to Didier.
Thank you very much, David. I'll share my screen. Okay. So happy to be virtually with you all this afternoon. Before starting, want to acknowledge that I'm joining you today from Chochake, which is also known as Montreal, and acknowledge the Kanyan Nation, keepers of this land. I'm very thankful for living and working here with my family and other colleagues. I'll discuss today a little bit about, of course, contingency management and its application within the context of a national clinical trial, looking at a treatment for methamphetamine use disorder. And that research is taking place on many unceded traditional lands across Turtle Island. So maybe one last piece too as well, which is important to me, is that of course today and a little bit along the line of that David's talk, I'll discuss about methamphetamine use disorder, which is, I think, a very specific context of substance use, and I also want to acknowledge that many people use substances in a non-problematic way. But of course, given the topic today, as you will see, I'll focus on people who started using and at some point had problems and unwanted consequences from that substance use. So and I'll get to that relatively quickly. I'll talk about the ASCME trial, which is an ongoing national clinical trial looking at different treatment for methamphetamine use disorder, and why this research effort at this specific time. Well, I suspect many of you, whatever your work is, and if you work closely to people who use substances in addiction treatment settings or even mental health settings, you probably know as well as me that methamphetamine and other amphetamine type stimulants have been, I'd say, kind of a large problem in this country in many ways, and that stems from, I think, some specific characteristics of that substance. First is a substance that, yes, can be used in a non-problematic way, but has been shown to have significant and high addictive potential, and sometimes that can occur quite quickly. There's ample literature showing that meth use in particular, but other stimulant use, are associated with a number of other problems, including from a cognitive standpoint in terms of psychiatric problems as well as physical diseases. We also know, and that's, I think, both concerning but also interesting when you look at overdoses in Canada. You see a growing proportion of these overdoses that involve methamphetamine in a way or another, and all this happens in the context of a substance use disorder for which we do not have currently approved pharmacotherapies for that condition. And that is the case in Canada and also elsewhere in the world. And it's, I'd say, of course, the research effort in addiction has historically been underfunded and probably not to the level of what we would have hoped for a number of reasons. But still, we've seen in the field of stimulant use disorder treatment a number of attempts in terms of pharmacotherapies to try to test treatment and sometimes repurpose some treatment that were already existing to treat amphetamine type stimulant use disorder, including methamphetamine use disorder, with a number, I guess, of failed attempts. Those are two systematic reviews relatively recently published, showing, for example, that naltrexone alone and modafinil were not superior to placebo in the clinical trials that were conducted among people with amphetamine type stimulant use disorder. We do have, and that's, I guess, the relatively good news, some more positive trials using bupropion as well as prescription psychostimulants. Again, those are two relatively recent meta-analysis showing that those two treatments were superior to placebo on a number of outcomes, that including stimulant use, and which is, I guess, in some ways encouraging. Of course, one thing, and for those who know that literature, you're probably well aware, we also have to be careful with our enthusiasm, knowing that in most trials, if not all, the effect size for these treatment is relatively limited. So we're talking about medication that can help, but that there's certainly no miracle to this point in terms of standalone medication for a stimulant use disorder. Still, and I guess that's also the good news, is the growing, I'd say, body of evidence we have, and the growing number of clinical trials looking at potential treatment for stimulant use disorder, again, in terms of medication, contributed to an effort from the ASCME and AAAP in the United States, publishing guidelines now almost 2 years ago. And some recommendation for the treatment and management of stimulant use disorder. And now we see a number of medication that are now part of these recommendation. And as you see, including bupropion, the combination of naltrexone, topiramate, mirtazapine, as well as methylphenidate. And so that's encouraging. We also see in those guidelines recommendation about psychosocial intervention, and as you see on the screen, contingency management being highlighted as the intervention for which we have the most robust evidence. Of course, bringing its load of questions in terms of implementation, as David presented a few minutes ago. So all this, of course, and to soon going to the point of the ASCME trial, but still providing some much needed recommendation in terms of how to guide our treatment and management, trying to help people with stimulant use disorder, but still keeping in mind a number of limitations as to these guidelines. First, of course, effect size being far from optimal. And that's quite clear. Second thing is we're still talking about recommendation where we're far from algorithm. We have a list of intervention that we can provide. We barely or not talk much about how to combine these intervention, whether or not we should combine them, whether it's cost effective and whatnot. And so I think we're still quite far from other guidelines that we have in the field of substance use disorder, as well as other mental health disorder for which condition we do have quite often a number of recommendation, including kind of algorithm level of evidence, but also, I'd say more importantly, how to combine these treatment and how to make these treatment available in the best sequences as possible. So I think there's a whole lot of work to be done in the stimulant use disorder field to basically go from very useful guidelines that are basically listing the intervention to guidelines that would be more clinically oriented and clinically useful, helping us to decide which treatment at what time and for which patients, and also potentially combining intervention. And that's also important, specifically when we talk about interventions that show less than optimal effect size and response. And so we're talking about a number of intervention that, except maybe for contingency management, where the signal is probably a little stronger, but most intervention where the effect size is relatively low and limited, we're talking about a condition for which combining potentially intervention may be quite a promising strategies to improve the impact that we could have on the people we're trying to help. And combining intervention, especially combining psychosocial pharmacological intervention, could be, I think, potentially useful in a number of ways. First, of course, you're targeting different mechanism, different symptoms, different problems. You probably have more chances of responding to the needs of people who, as you well know, have a number of needs in terms of both psychosocial, but also in terms of biomedical needs and physical comorbidities and whatnot. And so the ability to combine treatment does not only potentially provide the capacity to improve the effect of what we're trying to do and potentially decrease substance use, but it can also help to potentially target a broader range of needs and preferences by people that would seek that type of care. And again, that type of work combination intervention is also probably more aligned with what we're doing clinically speaking, where when we have someone in front of us, usually we'll think about of course, the various intervention that we can deploy and try figure out in a more individualized way with the person we have with us a treatment plan. And so that's a lot of what was behind the design of the ASCME trial, which is a pan-Canadian multi-site randomized control trial where we're testing, and I'll get to that in a few seconds, about the pharmacotherapy, which is idle stimulant with psychosocial intervention, in this case, contingency management combined with treatment as usual, which, as I will describe, include a number of psychosocial intervention. And so when we responded to the call of CIHR to basically develop what we thought at the time could be the most promising interventions to test, of course, we relied on the available literature and the evidence base we had at that time. With a number of interventions that have been shown to be to some extent effective, and of course at that time the idea of using psychostimulant was brought in addition to contingency management. Then what we've done at that time is also engage with a group of people with lived experience who acted as consultant throughout the design of the trial and also design of the intervention. And they provided a number of feedback. I'll go through that. Maybe I'll skip that a little bit. But in terms of the type of pharmacotherapy that we should use, also in terms of the outcome, where a lot of the feedback we got was that the objective by people could vary quite a lot, and going for sure from abstinence, but also from significant decrease of use. And in terms of psychosocial intervention, contingency management was not so surprisingly, but quite positively perceived, but with some limitation and clear advice, which were basically first that providing incentives to support behavioral change would make sense, but if the behavioral that is targeted is aligned with the participants or the patient preference and own objective, meaning not only abstinent, but also just engaging in care, for example, or whatever the objective was. And the other aspect was a lot of feedback around how providing incentives for negative urine was actually bringing his all many problems in terms of stigma, in terms of acceptability and whatnot. And this is basically kind of a lot of feedback that were used and quite useful for us to design the trial, but also the intervention that were to be tested. And parallel to that, and that was quite interesting at the same time in Australia, a colleague of mine, Rebecca McGetton, was doing some work exploring perception about contingency management in people who use methamphetamine, trying to understand a little bit why this evidence-based intervention was not more or better implemented. And long story short, their finding was also partly, I think, aligned with a lot of what David was presenting and a lot of our Canadian consulting group of people with lived experience was saying that overall it was not negatively viewed. The key question was how it was implemented, with feedback around the importance of flexibility in terms of goals, the risk of shame, some potential challenges when the design of the contingency management was too centered around gaming. Also some preferences around vouchers or cash versus other types of incentives. And also a lot of discussion that we've not addressed in the ASCME trial, but a lot of question around potentially trying to develop digital or remote contingency management options. Of course, relevant in the context of Australia, where the territory is similar to Canada, where there's a lot of people outside of large urban centers. And they've done the same work at that time with service providers. And I think, again, extremely interesting to see how service providers were providing very similar feedback as people using methamphetamine. Again, overall reporting quite a relatively positive view of contingency management in principle, but again, emphasizing the importance of implementing it with modalities that would be well aligned with client objectives and their own preferences. Also, bringing a number of interesting points around very more technical aspect, but for example, who's giving the reward, having, of course, some benefit when it's really integrated in clinical care, but also when it involves money, some discomfort with paying patients or clients. And again, the risk, especially if the target behaviors is not well aligned with patient preference and own objective, that these approach that in theory could be useful to decrease substance use that could actually lead to more stigma in inequity. So again, kind of overall positive feedback about it, but just again highlighting the importance of implementing it in a way that is aligned with patients or clients' preference and own objective. And also making sure that the very specific modalities are not increasing stigma, but actually help people to achieve their own goal. So that led us to develop a protocol for contingency management that was developed, and also that we tested in terms of acceptability with our group of people with lived experience. Where we decided to use a contingency management approach really focused on attendance to treatment visits, treatment that were defined as being between 15 and 60 minutes of length. That could include motivational interviewing, relapse prevention, harm reduction, intervention, responding to psychiatric needs, for example, and other type of clinical management, with a starting amount of $20 and increasing of $10 per week for a period of 12 weeks, with kind of an escalation. And when someone would not show up for a treatment visit, they would simply not have the allowed amount of money for that attendance, but not going back to $20 if they missed a visit, but just keep escalating if they would show up again. And so you have the amount of money that it involves there in front of you. And overall being integrated within, again, a treatment as usual that involves all the other intervention that I mentioned in terms of motivational interviewing and relapse prevention and whatnot, but also combined with pharmacotherapy, which is high-dose stimulant in this case, in this trial. We're using a 2x2 design where basically we test all the different combination, basically just treatment as usual with active medication, treatment as usual with placebo and contingency management, as well as treatment as usual plus medication plus contingency management. We'll recruit 440 participants. The main outcome is the number of days of methamphetamine use in the maintenance period of 12 weeks, with contingency management, of course, and medication. And so we are, and I will not have any data to present because we're basically a third in recruitment. So we have almost 150 participants recruiting in the trial, and we're still actively recruiting in Vancouver, Toronto, Montreal. We decided in New Brunswick now we'll have one in PEI, and then we're exploring actively potential site in the prairies. So that's where we're at. One thing that we'll do as well is also join the quantitative trial with a qualitative evaluation, so which is underway. So we're meeting participants before and also after participation to get more detailed input about their experience participating in such trial, but also more specifically about contingency management in the context of the trial, in the context of combination with treatment as usual, combination with the active medication. So that's something that is undergoing, and that will also, I suppose, provide us quite rich feedback on the experience of participants in contingency management and a protocol using contingency management above and beyond, of course, the quantitative data that we're collecting in terms of substance use and well-being and whatnot. Another thing that we're doing less related to contingency management, but we're also doing an extension study. So those who are completing the trial can engage in an extension study where they can receive medication for a longer period of time. For now, the extension study is conducted in Montreal, and we're looking to expand to potentially other sites. So that's the trial. And of course, not knowing the results, we're still recruiting, but at the very least will help provide data and evidence on whether or not providing contingency management focused on attendance to treatment is useful. It may be complementary and even improve help and the effectiveness of pharmacological intervention, and also start looking into whether or not it's worth combining intervention, knowing that there are costs related to medication, knowing that there is costs related, of course, to contingency management. And so what we know is that CM is effective, again, not based on ASCME data and this trial data, but just overall from the literature. The main problem, as I think David highlighted very well, is the problem is acceptability and feasibility challenges that makes contingency management a very an evidence-based, very effective intervention, but very rarely implemented in most clinical setting in most countries. Including Canada, but also Europe and Australia and elsewhere. I think one feedback we get from both clinicians, but also people that could benefit from contingency management, is the importance of developing, just like David showed, models using contingency management that are more acceptable, flexible, and tailored to the need of the population. And that would probably require more flexibility and new approaches, not purely based on negative urine sample. That was a little bit of the model that was at first used when the contingency management was developed. And I think there's also, and that's a little bit what we're trying to do with the ASCME trial, get a better sense of how to integrate contingency management and potentially combining it with other intervention to really potentially, and that's the hope, for example, in the ASCME trial, potentially use contingency management not only for its own effect, but also as a lever and a strategies to augment and improve the efficacy of other types of intervention, including medication, which overall I think still remains much needed, especially when we talk about stimulant use disorders, for which we have still relatively limited intervention that are efficacious and available. Of course, the ASCME trial involves so many people here in Montreal, but also across the country. So I want to thank them. This trial is also feasible and possible because of the support of CIHR, the support of the CRISM network, which is really the host of this clinical trials, and a number of other funding bodies, including Health Canada and other agencies. So I'll stop here, stop sharing, and I guess open to questions.
Thank you both so much. This is such an interesting area, and I'm so grateful to both of you for all of your work and your leadership in this area and for presenting. It's really exciting to see this work in Canada. So thank you for being here with us today. Please, if you would like to ask a question, please use the Q&A feature, and we're happy to take questions. I do have two that I'm going to start with. So the first one is, has contingency management been used or measured with other daily medications, for example, HIV medications or TB medications?
Yes, it has, for sure. I don't know the details of those trials, but I know that, it certainly has been extended, really beyond the addictions treatment area with effectiveness.
Okay, that's great. Thank you. And has there been research into increasing or improving intrinsic motivation if providers or individuals have issues with extrinsic motivation? Any thoughts or wisdom around that?
Yeah, it's a really interesting question. And, my understanding is that contingency management doesn't decrease intrinsic motivation. If a person is actually attending treatment and doing well and getting reinforcement for doing well, of course, their self-efficacy increases, which, undoubtedly increases their intrinsic motivation to keep doing well. So it's very reinforcing, and doesn't detract from that internal sense of motivation. The concern about it, lasting only while the contingency is in place has also been debunked. I mean, there's always kind of a drop off after any kind of treatment, because there's relapse happening, but there isn't this sense that it's only helpful when it's in place. And that suggests that it must be building on intrinsic motivation as well, that is retained.
Great, thank you. I do have one question as well. David, you talked about the philosophical objection to this type of approach being one of the barriers that really came out in your work. And I'm wondering if you could both speak to just your thoughts around that and how do we overcome that? Given the evidence that we have and the work that's ongoing, how would we overcome that?
Mhm. DJ, want to start?
I can start, and David, of course, please add to this. I think that the barriers and the objections are different depending on who you're talking to. And I think that we have to address those barriers very differently. I think the evidence shows that for people with lived experience and people would potentially be use that type of intervention, I think that there's a lot about fitting the intervention with their own treatment goals. That's one thing. I think that there's a lot about the potentially controlling perception of control that brings the idea of providing an incentives to change behaviors. So I think that in the way, and that's, I think, the art of contingency management is how you provide it, all the setting around when you provide the incentives to make sure that we refine a little bit how we're doing things so that we're less in a dynamic of control. I think of clinicians, there is also something aligned with the idea that sometimes objectives for someone can vary, it can be different. I think that there's also very practical issues about money, for example, and providing money and being the one having money and giving them to the clients or the users. And I think that in the implementation strategies, we have to take that into account and see who's doing what. And maybe it's not necessarily the therapist that is doing it, depending on the type of incentive. So I think that there's that. And in terms of decision makers, because I don't know, for example, in Alberta how it is, but I know that in Quebec, for sure, in other provinces, and I know in Australia it was the same thing. There's a lot of resistance from decision makers just because there's no line in their budget for providing budget to provide incentives. And quickly they can discard that idea. And I think one key here is probably for researchers, we have to be very mindful, making sure that we have, for example, we're able to provide some kind of cost effectiveness assessment for these decision makers, because I think that we do have an intervention here that can be cost effective, and you can reimburse the cost of one contingency management for one people very easily by just avoiding one emergency room visits, for example. So we have to speak that language as well. I'm sure David has other idea, but those are a few.
Yeah, I think you've kind of identified a lot of the issues. I mean, we know that change is very difficult, implementing new programs. I mean, there's a whole science around implementation science around, the array of complex factors that you need to consider if it's ultimately going to be successful. I know at the individual level, we were working in clinics with, experienced clinicians, doing a good job, feeling, good about their work. Some people were very keen about contingency management and, became champions of it, and others, much less interested. And we did a little bit of kind of qualitative interviewing about that. and didn't really develop any particular, there was one kind of, factor that was associated with reluctance of people. It was a variety of things. So it's very complex. I do want to actually make a comment about the cost though, because Didier is absolutely right. If we did a cost benefit analysis or a cost effectiveness analysis, contingency management is going to pay for itself for sure. I do think we have a lot to learn about, the size of the incentives. And I mentioned how, the fishbowl technique is a way of reducing the costs. In our trial, the average cost per participant was $60. So it was way less than what is planned for the ASCME trial. Now, we all felt it, we kind of followed what was done in some American programs that were older programs, and we kind of at the end of the day felt like we should have provided more. But even with the meager amount we provided, we got some pretty good results, right? So, what is the sweet spot in terms of, what needs to be the size of the incentive? And we've got lots to learn about that.
Great, thanks so much. We're going to do one more question. So are there any specific populations that we can find in addiction medicine? So for example, people with antisocial or borderline personalities, or different people from different cultures, perhaps, where contingency management is less effective or more effective, or any types of addiction where contingency management would not be a good fit? What are your thoughts on that?
I think that's a great question, and I don't have a great answer. I don't know if there have been a lot of examination of moderators. I think, we know some of the characteristics of people that mean they don't do well in treatment. They don't engage in treatment, whether that interacts with contingency management. I'm not sure. I mean, I know that our observations in this trial was, the amount that we incentivized was pretty low if somebody was a higher income earner. And that didn't seem to be a big factor. Like people like to get the rewards and could still, this is found money and they could still, save for something, or, just feel good about, about the fact that they're having their hard work acknowledged. So yeah, I don't know much about moderators. Maybe DDA does.
I think that there's been a little more studies and attention paid to the modalities and looking at sort of like the length of treatment, the length of contingency management, and the amount and the type of rewards and whatnot. I think there's a lot to do in terms of finding the best fit between that type of intervention and modalities and actually some personality profile and whatnot. And I think that leads me also to think, I think we're not in a situation where there's one gold standard for contingency management. I think there's a number of ways to implement contingency management that we should probably try to fit best with the population, the type of substance use disorder, personality profile, and whatnot. I think we're far from there in terms of data, but I think that's probably where we should go and try to individualize a little bit the modalities of contingency management to best fit the needs of the specific population we're trying to help here.
Great. Thank you so much. Thanks for taking those questions. So I'd like to thank both of you so much for your time and your participation in this round series. It was just incredible to learn from both of you. Just a reminder that this session will be posted on the CRISMPrairies.ca website. Our next rounds will be January 21st, where Drs. Kate Kaliza, Prab Lal, Sherry Klassen, and myself will be doing a presentation called Stages of Change, Launching a Successful Inpatient Addiction Medicine Consult Service. So with that, we'll close this session, and thank you again for being here. Have a wonderful rest of your day.
Thanks, everybody.
Thank you.